and welcome to episode 15 of the EMS Handoff podcast, your source for all things EMS. Before we welcome back our co-host for this week, we'd like to thank our host, the Journal of Emergency Medical Services, for all they do for us. So make sure that you stop by their website at gems.com and see what they're doing for EMS, including hosting all of our prior episodes. Again, visit them at gems.com. Guys, before we get started and before we talk to my co-hostess with the mostest, we're going to talk about one of the newest things. We've been talking a lot about all the cool new stuff that we've had going on. And if you've watched our social media over the last couple of weeks that Eric has been putting out, you've seen our most recent release. It's our official EMS Handoff clothing line. If you're watching the video today, you kind of see me in the red one right here, but we've partnered with Pursuit Outfitters to make our EMS gear, handoff gear, that is stylish and comfortable, available to you. You can find more available at pursuitoutfitters.com. Click on culture and you'll see the EMS handoff line right there. You'll find t-shirts, long sleeve shirts, and for those that are in the cold areas of the country right now, we have some hoodies, and we do always like to shout out with Pursuit Outfitters. They also support the organization Love 146, which their primary mission is to end child trafficking. So every time you purchase one of our shirts, it continues to help stop that injustice in this world. So welcome back. Another week, Bradley Dean. Things going crazy in the handoff world. How are you doing this week?
Doing great. We've had a lot of development and stuff over the last week. I'm gonna let you tell everybody about what's going on, but we've got some good guests lined up and some exciting stuff coming up in the near future. But this week I'm actually at home, so that's a good thing.
I was just listening to last week's episode in getting everything ready and seeing it go out, and I realized I was giving you a hard time about, really thinking you're just sitting at home every time and just have little pictures in the background, of where you are, and so you've got it made sitting in the house just chilling and doing stuff, but you really make it look like you're working, or we see. So, but as Bradley said, he's got several. The next coming weeks. The next couple of weeks are going to be awesome. We've got some great guests coming up, but I'm not going to spoil all of it, because we're going to go over to Middle Tennessee and see what the West Side co-host has put together for us. Eric, you've been busy behind the scenes this week.
Yeah. So by the time this airs, our website will be live, and I know for many people who visit this, maybe through our Facebook or through other ways of getting this podcast, there will now be just a unified way to go. One website. It'll be emshandoff.com. You can just click on it and go to any episode that you want. So you'll finally be able to send that out, not search through Facebook or Gems or whoever else. You can just go to our website and we'll have it all there. I'm sure we'll be filling it up with a lot more useful stuff that will help people out.
Well, just seeing that as you've been building a little bit, we've got the audio that the embedded player from Gems already right there, so you can support both Gems and us. We've got our video, which is something else that's been big here recently. We've released our last couple episodes in video, just like this one as well, putting it out on YouTube. You see it come out at the same time the audio does. So a lot of this stuff we've been talking about is finally here. But you don't want to hear an hour about us talking about what's been going on. You just want to enjoy the great guests that Bradley has been putting together. So let's go ahead and kick it off for this week.
So tonight our guest is a well-traveled EMS educator. He's a powerful and inspiring speaker at various conferences. He's a quality assurance analyst and clinical educator for MultiMed Billing in Baldwinsville, New York. He's has more than 18 years of fire and EMS experience. He's been an EMT in 2003 and advanced to the paramedic level in 2006. In 2008, he studied at the University of Maryland, Baltimore County, and obtained a certificate in critical care transport. He's worked as a critical care paramedic since 2008. He's done a lot of interesting things. He speaks at conferences, hosting classes. He's reviewed textbooks for various publishers, specifically for Jones and Bartlett. He's an advocate. He's done a lot of stuff with Finger Lakes Regional EMS Council. And he loves doing stuff with Geneva Fire Department, the Boy Scouts, the Rotary Club, Ducks Unlimited. Jason Haag, thank you for joining us tonight. I'm going to turn it over to you and let you kind of give a little bit more of your background.
Yeah, of course. Thanks, Bradley, and thank you, David and Eric, for having me tonight. It's really exciting to be here, and it's really exciting where you guys are heading with this and what you've done. It's excuse me, it's a pretty awesome thing with EMS and not being able to spend a lot of time in person. So, like I said, happy to be here. Bradley kind of hit all the important parts on me. From upstate New York, right between Rochester and Syracuse, where it's balmy 18 degrees right now with 4 inches of snow on the ground, and we'll have a foot more by the end of Tuesday. So
4 inches of snow. We've
Yep.
had like 6 inches of rain.
Outstanding.
And then, just since we're all down here, except for Jason, then we have that 6 inches of rain. Then it turns into 6 inches of ice. And then we have an inch of snow on the top of that. And then all those New Yorkers are like, man, those Southerners, they don't know how to operate in all this. Yeah, okay, we got you. Well,
my 6-year-old is out playing lacrosse today, so it's all good.
Hey, it's all good, right? It's what you're used to. Well, I do have to say, Jason, just since we've been on here, you can tell this guy is tech savvy, which is one of the reasons he's going to be good in these EPCRs. Just in the short period of time we've been on here already, he's gone through 3 different Zoom backgrounds and found his way into our very own EMS handoff. That's an awesome thing. Jason, welcome. And so we're going to spend the next little bit talking about documentation, huh? And my understanding is you have a way to make this fun, enjoyable, and the best thing of an EMS professional's career, right?
I wouldn't go that far, but it's a necessary evil that we really need to that we need to have a lot of knowledge about and kind of dig into, and for some folks kind of dust the cobwebs off of it a little bit. I think we spent about 5 minutes in EMT class learning about documentation, because every EMS instructor, myself included, is like, I don't want to teach you my way to document, because when you get to your agency, they're going to have their own rules, their own expectation, their own software. So I kind of take an overarching approach at it and really just look at the components of what needs to be in a PCR, and what's gonna save somebody from an uncomfortable time on a witness stand. God forbid they ever end up there. It's going to provide a chart that provides awesome medical information and clinical information to the allied healthcare professionals that are going to take care of that patient after we do our job. And also to make sure that if you're an agency that gets reimbursed, that you get as much reimbursement as you possibly can. That's kind of my 3 tenets of documentation.
So as we take a look into the start, and I think you made a very valid point there at the very beginning, is the fact that with documentation, the fun stuff of the EMS is what we do when the alarm goes off. We're headed to somebody's house. We're going to a car wreck. We're going to, this, that, or other call, which challenges us. And then when we get done, we kind of hit that needed evil. And so everybody kind of says, hey, I've got to just get this done and get it turned in. But our documentation actually has significant ramifications, not only, as you mentioned, in the compliance side, as far as billing requirements, as far as state requirements, but it also is going to be one of those things that touches us if we do have to go to the legal side. And also documentation is being used to change the practice of the EMS now, as we collect. So it's research. So while we're being inundated with calls day in and day out, we shouldn't just discard the documentation side and just say, hey, we want to just get this done. We really need to focus as much on the documentation side as we do the patient, right, Jason?
Absolutely. We get a lot of people, most of my clients are in the Northeast that I deal with. But I get it at conferences all the time. People are like, what is with this NEMSIS thing? There's this crazy lot criteria that is making me put all this data into my chart, and it's driving me crazy. When Nemesis 3 first broke out, people were going crazy about it. And you get new folks that are jumping into electronic documentation for the first time. Drives them crazy. And as you said, David, my retort to them is really, these are all data points that are used to drive where we are now and to drive our future. EMS protocol is no longer based off of a bunch of docs sitting in a room saying, oh, hey, some people do this in the hospital. We think they could do it in the back of a metal box in the field. So yeah, maybe the EMS providers could do that. And, well, this med works okay for us. Maybe we'll let them try it out there. That's what EMS protocol was 20 years ago. It's evidence-based and data-driven protocol now. And that's where they get it from, is from all this electronic data that we have an opportunity now that we didn't have before to collect it at a regional, state, national level, pull that data for a report, see what works, see what doesn't work, see what we need to do better on. And we drive our practice from that. And the nerd in me finds that to be extremely exciting that we have that capability.
Well, I simply take a look back, and I think it was in the 2005 cardiovascular care updates when CPR really started to change from that. As you mentioned, just we get a bunch of emergency room physicians and nurses together, and they say, hey, this is what we think works at our location. I remember looking through all the different studies, and in one of them specifically, just talking about compression to ventilation ratio, not even talking about number of compressions or number of ventilations, just how should we put these two things together. There was over 400 studies that were conducted on that. And now we're not even paying necessarily for studies to be done. We're just taking real-time data and saying this worked, this didn't. And it's because of those documents. And as you mentioned, though, then we have to turn around and actually use that data. But let's get into the document itself. So let's go ahead and introduce us to EMS documentation, just kind of a high-level view, and then we're going to jump from that 30,000 down to the ground level.
Sure, absolutely. So there's like 4 different parts really to documentation. I call them the foundation of documentation. There's these 4 pillars that hold up the base of documentation. And if one of these falls, you don't have documentation at all. The first thing to remember, excuse me, unfortunately, is that as EMS providers, as far as reimbursement is concerned, as far as governing organizations are concerned, we are unfortunately still seen as transportation and not healthcare, at least at the federal level and at the CMS level, Center for Medicare and Medicaid Services. We are still seen as transportation. And any payers from CMS, Medicare, Medicaid, and unfortunately most others, only reimburse us for our services if we transport somebody to the hospital. ET3, which we could talk about for multiple hours on another episode, if you haven't already, which is really exciting. That's hopefully going to change that. There's been some COVID exemptions that have changed that a little bit. But the hard, fast rule is that if you don't take somebody to the hospital, you're not getting reimbursed for it. And a little bit of EMS trivia is where do we fall nationally? Do we fall under Health and Human Services? No, we still fall under the Department of Transportation, where we did in 1972, right? So we are still very much seen as transportation only. The other pillar.
Before you go that, if you get into listening to Bradley or Eric very much, you'll hear, because I have a long little diatribe that I put on that. Dr. Kramer and the EMS.gov people are doing awesome things, but it's hard when you sit under the Traffic Safety Administration, which was our home after the Accidental Death and Disability White Paper. There's a reason. You know, we were born out of the interstate system, so hey, that's great. But it was because they wanted to decrease morbidity and mortality by adding that treatment further in the field,
right? And
not just because of transportation.
Yep,
because they were transporting them before then.
Oh, sure. Unfortunately, as far as reimbursement goes, we are still just only seen as transportation. Absolutely. So the other pillar is interventions, right? And we'll get into this deeper, but documenting each one of your interventions individually and clearly in your chart is huge. I'm not going to steal the thunder on that particular piece, but we'll get into that a little bit later when we dive deeper into this. The HPI is also important. The history of the present illness, history of the present injury. That's That's painting the picture, right? A chart is a blank canvas. You start out with a software program, or if you're still on paper, which I'm kind of jealous about, if you're still on paper or you're using electronic charting software, that's your canvas, right? That's your overarching canvas. And your HPI is really where you take those intricate brush strokes, paint that picture, add that color, and make the person that's looking at this painting have an understanding of what you saw, what you did. Mainly what you saw. That HPI is the reason that you're there. That encompasses your OPQ or STI. And a lot of people, I say OPQ or STI, they're like, what the heck's the I? So many times we forget to document the interventions that were done by our colleagues in the fire service, in law enforcement, lay people, or the patient themselves, what they did prior to our arrival. We'll get into that a little deeper as well. And then the last one of the 4 pillars is the chief complaint. Both the chief complaint that the dispatcher gets and the chief complaint that the patient tells us when we get there. So that's your overarching, I'm about ready to jump out of the airplane view.
All right. So getting into that HPI, it's one of the ones when I'm in the classroom that I like to go over and when I specifically talk, and coming from the academic side, I take something that you said very earlier to heart, because it is something that we continually face even on the paramedic side, which we try to spend a lot of time on the documentation is, in our region, I covered 2 of the 8 EMS regions within the state of Tennessee. And within there, we have about 30 different EMS agencies in those 2 different regions. And I don't know that there are 2 services within there that document the same. So we try to provide kind of a holistic approach and focus on all of them. But this is what you said right here is kind of key to me, is that you use the term a blank canvas. And so one of the ways that I describe it, and this kind of ages me because you don't see these anymore, but back in the 90s, you saw these 3D pictures, the ones that if you just barely look at it, it just looks like random stuff. But if you sit there and kind of stare into it, you see that picture kind of develop. And I say, hey, you don't have to develop it to that level, but that's what you're ultimately doing is conveying everything that you saw into something that 5 other people may have to look at to determine billing, to determine the legal aspects. Did you meet the standard of care if it goes in the court, those kind of things. So as you're painting this, you don't have to look at those multiple layers to get to that 3D level, but you do need to make sure that whoever reads this, they don't have a camera view of what you saw, but they need to be able to recreate it.
So, and I want to jump in where David just did. So a couple of quick things to tie this back into the clinical aspect. The HPI documentation plus the documentation of the patient's past medical history leads us into the clinical documentation, the clinical treatment that this patient gets, the clinical bundle that the patient care provider yields to the patient upon initial contact is really important, because if the patient has a history of previous MI within the last 5 years, they're hypertensive, they're short of breath, they've got wheezing, I know that is now CHF and not asthma.
Right.
So, but anyway, so I step off my soapbox now and turn it back over to you.
Yeah. And, that was a great segue into the next point that I was going to kind of make with tying the HPI and all the clinical stuff together. Is we all know that oftentimes the receiving ED docs don't necessarily get a chance to read our chart during their initial care, right? But if that patient gets admitted, if that patient goes to an ICU, if that patient is transferred to another care team and they're not a treat and street patient, they're not discharged from the ED, if they get discharged, if they get admitted rather into the hospital, our documentation is going to become important, because that ER doc, or at least that ER nurse, got that face-to-face handoff from us as EMS providers, right? When that patient goes to the unit or to the floor, that's gone. So that initial look of what was going on with that patient, how they presented, that led to them being admitted to that unit at the hospital, That's your patient care report. You're not there for that provider to ask questions to anymore. And you need to write a document that basically takes that provider who's reading it from where they are in the hospital to the scene where you picked that patient up. You don't have a chance to talk to them. They weren't there. You need to remember that when you write these sections of a patient care report, other than just the drop downs, right, that data collection stuff, when you're doing your free text fields and you're elaborating on your interventions and everything, you're writing a story. We talked about painting a canvas, but you're also writing a story. And a lot of people that I've spoken to during this whole quarantine thing, they might have taken up a little bit of leisurely reading. And when when you're not reading for academics necessarily, and you're reading for leisure, the author's job is to take you somewhere, is to have you develop a picture in your mind. And that's really the burden that you have as an EMS provider or any other healthcare provider when you're writing a chart, is that somebody who was not there that could read it has a clear understanding of what that patient's presentation was and what you did for them, and more importantly, why.
This is, not this past week, but a couple weeks ago, had the opportunity to go to the National Association of EMS Physicians conference, virtual conference that they did this year. And in one of the areas, we got into a comment during the presentation when we were talking about documentation. And I said, this would be a great opportunity for a true electronic health record system that would allow us to pass that document on. So as soon as we inputted it in, it would go to a central database that they could then call up. Because in the academic side, when we're teaching our students, I focus on this patient scene being from A to Z. So
Sure.
A would be that, the time of the onset of injury or illness, and then Z being when they're completely done, whether that's after rehab, discharge from the hospital, whatever occurs. And I said, if you take a look at the way most of the areas are set up, you have a fire base or some other first response agency that's there, then you have the transport side, emergency department and such. And so if we're going to operate the most efficient and effective way possible, that first response is going to go, say, A to F. They're going to be doing all that initial stuff, and there should be a way to pass that on to the next unit, so that instead of on the transport side, me going from A to M, now I'm going from F to M. I can just pick up and transition and take that over. And the same thing in the emergency department. We've already done A to M. There's no reason for them to completely go back. But if somebody forgot to write something down or wasn't listening to a specific area of our handoff report, then that next layer is going to be missed. And now you have to go all the way back to the beginning. And then, as you mentioned, once they go up to the floor, only typically what's done in the emergency department gets passed on. They don't know the stuff that's led up to where they are. So that would be a great opportunity for a patient care report to actually travel with this patient somehow. But as you mentioned, writing that and letting them know. So a lot of places have gone, and we used to have our EPCR system that we use in the classroom set up on a chart method, but we had several that use chronology. Is there a recommended system that works best as far as completing narration?
So that's a great question, and the answer to that is no. There are a couple of them out there. There's Chart. There's Chart-A with an E added to the end of it.
So
for some events and things like that. But there's really no actual. There's SOAP. There's DRAT. There's Chart. Those are really the big three methods. But there isn't an overall or overarching one's better than the other format, if you will.
Just finding one and making sure you get the information across.
Yes.
All right. Now, we do know with EPCRs, especially there, as you mentioned, you've got a lot of the data fields, maybe vital signs, and maybe, some will actually have you do interventions that are accomplished there. But one of the things that we do need to make sure and do is that we validate the information that we put in those drop-down boxes. And if we restate those during the narration portion, that those two match as well.
Yes. one of the functions of some EPCR vendors is actually a drop-down created narrative. I would caution against using that simply because repeating information is sometimes helpful, but more often than not, it is often detrimental.
Oh, let me jump in. Double documentation.
Yes,
It's horrible.
it is. Agreed.
And he even threw the fist down on that one. That one's great.
Can we get him an EMS handoff gavel, like one that has it like wood burn in the side of it or something?
We may have to look at that. We still got a little while before we get to Christmas again, but we may have to because he got right on that one.
Yeah,
he did.
What would be the big question behind that? Because I know there's some instructional methods that teach, double documentation, get it in the drop down boxes, but also make sure you document it in the narrative as well. Is it either or, and why not if it's not, if it's not either or, if it's just one or the other, why isn't it both?
A lot of things with that, Eric, really come down to the fact that the auto narratives put in a lot of information that doesn't need to be in your narrative. Like you were dispatched to 123 Main Street, anywhere USA, and you found a 57-year-old female who was 160 kilograms, blah, 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 blah. You already read that once, right? That's all up in the patient information. But just documenting that story is important. I feel that there's not, I think the term literary license is the one that probably applies the most here. If you look at it from an academic standpoint, there's no literary license, if you will, when that narrative is auto-populated by the drop-downs that you've selected previously in the chart. And then another problem is provider laziness. They're like, oh, I had the auto narrative turned on. I'm done. I don't need to include anything additional. And that's where the failure happens. The narrative is done by auto population. They've got the auto narrative button checked in the back end of the charting software. They auto populate a narrative. Oh, there's text in that box. I don't care. I'm done. But all those drop downs really didn't paint that picture. It looks like a paint by numbers outline at the moment. And you didn't go in on that paint by numbers app and click in and put in the little, the colors to make that picture the whole thing. To me, it breeds complacency, and complacency breeds all things bad. So now that's the personal opinion of Jason. That could be totally wrong. But in my travels, in the thousands of charts that I read a week, that's a pattern that I've certainly noticed. And in the world of interfacilities, we could talk about interfacility documentation for a whole nother episode as well. But in the world of those, if it's an auto-populated narrative, medical necessity is almost impossible to prove. So you now have an uncovered transport, and that's certainly problematic.
So let's go ahead and we're going to kind of wrap back around to where we are, but let's talk about that, because as you just mentioned, one of the big things that EMS operates on is reimbursement, through billing practices. So as we take a look, it is, while everybody thinks it's the insurer's automatic responsibility to pay whenever something comes in, their ultimate goal when things first occur is to not pay if they don't have to.
Absolutely.
They're in it. They're in it. They're a business. And I'm trying to remember, I think the movie was actually Rainmaker, quite an interesting movie. It had Matt Damon and Danny DeVito in it. Brand new attorney takes on this case, and they get into kind of that philosophy that, insurers are not there necessarily to pay. Now, if everything is there, they do. So let's take a look at it. The fact that the majority of our services are based in reimbursement. They bill. So we bill these things. And if we have, say, a $10,000 a month, and obviously we're not talking about most annually, just using round numbers. if it takes $10,000 a month to operate your ambulance service, and you only receive 50% of that through your billing practices, and you go back and you don't get much collection through other services, that service isn't going to last very long. They're not going to get new equipment. The ambulance is going to break down, not going to be able to pay people. So this has a very tangible tie back to how the services operate day to day.
Absolutely. And, medical necessity is generally audited for inner facilities, but CMS and other payers are starting to actually look at 911 calls with it as well. And yes, we are mandated responders in most places as EMS providers, but I think there's going to become a time where these payers are going to say to some of these frequent resource utilizers, is what I'll call them, that maybe this trip to the hospital for the toe ache at 3 a.m. wasn't necessary. And I think as ET3 evolves and some of the practices with EMS revision as a whole nationally evolve for the better, this is going to be looked at a little bit, because payer insurers are going to kick it back for non-necessary ED visits. They're certainly going to start to kick it back for non-necessary ambulance rides as well. So having that that narrative, that I call it a free text narrative, right? The non-drop-down generated one is important to include those brushstrokes.
All right. So talking about the narrative in itself, then, as we get into there, what kind of research do we see utilized out of those drop-down boxes and such before we go much further?
So I'll jump in real quick about the research piece. So I don't care which software vendor you use, the drop downs allow us to do a little bit more research. So if a drop down box, they're coded certain ways. So the drop down box allows us to be able to select the type of fluid that we give, how much fluid we give, the type of angiocath that we're selecting. All of that is in a drop down box. If I don't put that in a drop down box and I put that in the free text, for example, normal saline, we went through, I want to say it was around 253,000 different types of records. We found normal saline documented 35 or 36 different ways. Everything from 0.9% to 9% saline to NS versus capital N, little s, to normal saline versus one word versus two words. There was 35 different ways that it was documented versus a single code for a drop-down box. So if we're really going to advance the profession, we can use that documentation with those drop-down boxes, the way that it's coded by whatever software vendor you use, to be able to pull that information out to see what we're treating, how we're treating, what we're giving, how we're selecting things for different patients. So it gives us a little bit better of a picture of what we're doing. So using those drop-down boxes is the key, not the double documentation, not the just putting in the narrative, but using those drop-down boxes.
Yes, especially in your interventions, which I think we're going to at some point segue into, if this isn't the segue into interventions. But that's an absolutely valid point, and if I could high five you and buy you a beer right now, I would, because that was 100% on point. So here, high five.
Well, since we're already high five, since we're already segueing,
while we're doing that, I got to give props to Dr. Mike Hubble and Rimley Crow for those, because
yes,
they told me a lot about the research piece of that.
So since we're already segueing, we might as well go ahead and segue. And in this case, we're not talking about the little motorized scooters that would go around town. We're going to go ahead and talk about ALS 1, ALS 2, talk about those interventions. Go ahead.
Yeah, so interventions are huge, right? And Bradley eloquently stole some thunder on that, and that is absolutely fine. Uniformly documenting these things is huge. Now, I understand in your, depending on the software, your intervention log, your activity log, whatever it happens to be called, there's drop downs that can coincide with each entry that you put in. Initiate IV, cardiac monitoring, wound care, operations. The list continues. Those are actually really important. They're not one more stupid little drop down that I've got to click on to make the chart lock. They're really important for a couple of reasons. The most important one is the one that Bradley mentioned, is research, is your agencies being able to figure out how much saline did we use in the last quarter? How many angiocats did we use in the last quarter? How many flipping bags of EKG electrodes did we use in the last quarter? That helps with your inventory maintenance. That helps with budgeting. That helps with making sure that you're going to have enough supplies in that supply cabinet after your next call. That helps when we look at the bigger picture that we talked about earlier about protocols. How often are our providers using angiocats on cardiac arrests versus IOs? That's a great thing that a lot of places look at. It also links to training. You want to figure out what your training department and your agency should be doing. And I used to do this when I worked at commercial EMS and managed a training division of this agency, is we would look at training and QA would mesh together, and QA'd say, listen, these are our percentages of success on IVs. These are our percentages of success on endotracheal tube first pass success rates. And looking at that data would mold our training plan. And agencies have that data available to them if it's documented correctly to be pulled. And you could build your training plan off of that. Spinning into a different direction, though, unless we want to stop here and discuss that point for a quick second.
Well, let's stop there and discuss for
All
a
right.
quick point, because there are a couple things that I think are really kind of taboo, need to be discussed here. Is how many providers out there are actually 100% on initiating an IV first attempt, or initiating an airway management technique, a blind inserted airway device, or an endotracheal tube, or something like that. When we do a technique, an intervention, it is, I would say, critical, but it is definitely important that every time that we attempt something, we document it.
Yes.
So if it took us more than one time to start an IV, it's okay if we miss, because we know that there's not a healthcare provider out there. Right? You could be the best trauma surgeon out there, and at some point in time, you're going to make a cut that's not exactly 100% right. And it's how we go after that. But if we going into the courtroom and they say, so you got this on the first attempt. No, I did on the second attempt. Well, why did you only document one? It causes problems. But as you were mentioning, even taking that into the training side, hey, all of a sudden I'm seeing a significant drop associated with IV starts. Well, as an operations person, I can tie that back and say, oh, hey, we changed to a new type IV catheter at the same time that we saw these go down. So maybe we need to bring them through and do training with these new IV catheters versus just putting them out in the field. So making sure to document every attempt out there that you do is not only important for training and legal, but overall the documentation practice in general.
And I just want to add on to that like when we fail to document that we've missed an IV, a lot of it is we don't want to admit that we've missed something in a legal document because we think it's going to come back on us. As long as there was no complications and injury or harm done, which you should document as well. I'm not saying you should neglect that. It's not only for monitoring the supplies, but isn't it also good for colleges that you get students from, or the training officers at institutions, to know, oh crap, this is something that we need to look into. And so there should be a little culture of encouragement that, hey, document your failures. We need to know that, if not just from a statistical perspective, but also from training, so we can figure out, if there's a gap. This way they can speak to it more smartly and fluently to somebody and be like, well, hey, your students that come out, they're not very good at IVs. Okay, great. Do you have data? Oh, absolutely, I do. Here you go. Here's the data that I have for it. So I don't know if you guys have had any exposure to that or not.
Eric, will you say that again? Culture of.
Oh man, I can't.
And that's why you need to have a QA program that is set with a culture, a publicized, accepted, and practiced culture of it being educational and it not being punitive. That is the problem that people run into with QA so often. And I see everybody's head nodding, and I'm sure we could talk about this for a month's worth of episodes. But having a QA program that is purely based on education and actual quality improvement versus punitive measures is huge. And you change that culture, you will then, I think, see an increase in more accurate reporting.
Well, and I think, this is where we can go to the hospital side. Hospitals have long since, and I understand that the terminology and really kind of the mindset of them have changed as well. But they would have morbidity, M&M conferences, morbidity and mortality. Anytime they had a negative event, they would get together. Now, at times, part of those were punitive, especially if there were new people. But one of the ideas is, we learn from our mistakes. Let's, go over that. And so they would do that. And we need to kind of take that into our perspective as well. This is no longer, as we've already talked about, just hey, this is what we think works or not. Hey, there's evidence here. We can take a look. This is how we can turn around and make Jason a better provider. Look, this is what Eric has been doing. This is how we can make Eric a better provider. This is how we can make David a better provider and Bradley a better provider with all of this information. And so for us to say that we missed an IV, going back to what we were talking about earlier, an insurance company is not going to reject a bill or reject a request for billing because you missed an IV. They're going to, if there's other issues in our documentation, but so it should be that, hey, these are learning. Why were you going from 75, 80% initiation rates of whatever treatment you're doing? Now you're at 30%. Well, we've got these new IVs and I'm not as good with them because I practice with the others. Well, let's get you an IV arm and some catheters and go to town.
Yep. And I think, just as I said, bringing those two things together and building that culture of change, if you will, that catchphrase that so many people use but don't practice is important. And I actually used to, working with the QA division at my agency that I was at for quite a while, is we would actually have providers who we'd identify, and if they were comfortable, we would do a quarterly grand rounds for our EMS agency. And they'd present their case and what went well and what went horribly wrong. And it was huge. Those were our con ed sessions that were more well attended than anything else.
Awesome.
So
you were getting ready to transition into another route of intervention. So let's go ahead.
So interventions are huge, right? So that specific drop-down documenting and categorizing of each one of those interventions that you log, other than just vital signs, right? Because those, depending on your software, the vitals and the interventions could all be in one section. You've got vitals up here, interventions down here, whatever. Categorizing each one of your interventions is a big deal for a couple of reasons. One, it helps for data that Bradley mentioned, and David and Eric kind of jumped on the coattails there. Huge stuff. It also helps in determining what level of service is in your chart. Is it an ALS1 call, an ALS2 call, or BLS? BLS obviously is nothing advanced. An ALS2 call though is a little bit different. ALS1 calls I call blip and drips. The blip being the blipping or beeping on the cardiac monitor, and the dripping being I put in an IV. Blip and drips. Those are your routine, standard, 90% of the time bread and butter ALS workups. Put them on the 4 lead, did a 12 lead, all look good. I put in a lock because protocol told me so, or I had an index of suspicion that the patient may need IV fluids or IV medications soon. Or you actually administered a couple of IV medications or other medications. That's fine. And that's ALS 1. ALS 2, when you have a billing coder look at your chart to determine the appropriate charges for that chart, they're going to look at the intervention log, and they're going to look to see, and I'm quoting the Chapter 10 of the Medicare Medicaid Manual for Healthcare Reimbursement here. An ALS 2 level charge is the transportation by a ground ambulance and the provision of medically necessary supplies and services, including at least 3 separate administrations of 1 or more medications by IV push or bolus or continuous infusion. Now, that does not include any crystalloid fluids. So you're probably thinking, oh, maybe if I flush the IV 3 times with the saline flush, it's ALS 2. No, somebody smarter than us already came up with that and decided that didn't meet ALS 2 criteria. Your diabetic wake-ups, D10, D50, D5, that doesn't work either. Anything that's a crystalloid fluid doesn't work. Isotonic or hypertonic crystalloid doesn't matter. If it's a crystalloid, doesn't count. There's some other criteria, but I want to talk about meds for just another minute. Think, oh, wait, 3 meds? I had this crazy chest pain call where I gave the guy 324 milligrams of aspirin. I gave him 5 0.4 milligram doses of nitro and 2 4 milligram doses of IV morphine. That's ALS 2. It's got to be ALS 2. I gave him all the meds in the world. No, you only gave him 2 IV medication doses. And the reason that it has to be IV or IO is because if you look at the national scope of practice for an EMT can give PO medications. They could give or assist a patient in taking sublinguals. An EMT can provide inhaled or nebulized medication. They can give medications intranasally and intramuscularly. It doesn't matter what the med is, it simply looks at the route of administration. And other than IV or IO access, an EMT could use all the other routes. So that's why IV medication administration is wholly ALS 2. There's some other criteria that will get you an ALS 2 charge. So transportation in a ground ambulance. We could talk about air ambulance reimbursement, but that's a whole other topic. All right. It's medically necessary supplies and services and the provision of at least one of these procedures. And I use an all-inclusive term here called Edison medicine. Any kind of manually delivered electrical therapy. So manual defibrillation. Having your life pack or Zoll or Philips set in AED mode and delivering a shock as an ALS provider will not get you ALS 2. You have to look at the rhythm, manually interpret it, manually select a shock dose, and deliver it. Cardioversion will get you ALS 2 as well as cardiac pacing. Now, it's important to remember that none of this has to work. It simply has to be attempted. It doesn't have to be a successful defibrillation. It doesn't have to be a successful cardioversion. And you don't have to get successful electrical or mechanical capture with pacing. It just has to be attempted. Endotracheal intubation, an attempt, is considered ALS 2. Supraglottic airways are excluded. There are some areas of the country where EMTs are inserting supraglottic airways. Not all of them, but some. So supraglottics are not included. The ET tube does not have to be successful. It simply has to be attempted. Needle chest decompressions. I hope you're successful with those. They're pretty easy. They're so easy where I'm at that we train law enforcement to do them.
You don't want to say that out loud because then you're going to get another provider can do them, and it won't be LS2 anymore. So got to be very cautious.
No disrespect to my colleagues in law enforcement. I also serve on a tactical team, and we've trained them how to do needle decompressions.
As they should.
Yes, and that'll get you ALS2. Surgical airways, I have made my entire career without doing one on somebody who's alive or freshly not alive. I've done them all on cadavers. I intend to continue doing them only on cadavers. Or IO access. And that made the EMS manager in me really, really happy when that finally got added, because IO needles are about $150 a hit. So anything IO and any of the other criteria that I listed is going to get you an ALS2 charge. And depending on your area, your zip code, whether you're rural, super rural, urban, whatever, depends on what your usual and customary charges are. That's a whole different topic. But your ALS2 charges are typically significantly higher than your ALS1 charges. So documenting this clearly gets money that otherwise is often left on the table into your agency.
So
I want to jump in real quick, David. I want to joust at EMS documentation programs and EMS billing contractors. Sorry, Jason.
It's all good, man. It's all good.
We don't ask nurses, nor do we ask physicians to select the level of reimbursement in their documentation.
Nope.
Why in the world do we have that selection for EMS documentation where our providers have to select BLS, ALS1, ALS2?
I have no idea, because it's usually wrong.
I know, but
right?
We try to teach them that. Let's just teach them how to be good care providers.
Yep. The only reason I touch on this is simply to underscore the importance of accurate individual intervention documentation. That's it. I don't expect Eric, Bradley, David, Susie, Johnny, whoever happens to listen to this, to remember what ALS2 criteria is. My only goal is to make sure that you understand that if you document clearly, individually, that if you do it the right way and it's a bad call, you're probably going to get more money. But why does that up on the, you're probably thinking of the upper pages of some electronic charting software programs where you have to, what's the outcome? Treated and transported BLS, treated and transported ALS1, treated and transported ALS2. So I don't know if that's a NEMSIS data point, but it needs to go away. I agree.
Yeah. So my thing to vendors and NEMSIS that are listening to this, take it off. Make the consultants do their job. Sorry. Back to you.
Well, and
motion seconded. All those in favor?
Say aye. Then we go into the most important of every meeting. Can I entertain a motion to adjourn? But we're not there yet. So one of the things, especially at the provider level, the key is not making these decisions based on the money that's out there, based on what's right for the patient. But understand that whenever you do a necessary intervention, it is documented. It's not one of those things that you need to be, well, I've given my nitro, I'm only going to put that, or like I said, 1 attempt on an IV, you're going to only put 1 attempt, even though it was 2. You need to document thoroughly. You also need to make sure that your clinical aspect is on point. You're doing what is right. If you need a, nasal cannula at 2 liters, if you need a non-rebreather at 10, if you need a back valve mask, you're using those. If you're only needing a supraglottic airway, even though those may constitute an ALS1, hey, that's what you need. If it's an endotracheal intubation, you need something more secure, and it's in place, hey, let's do that. Because the rest of them were kind of an advocacy side, kind of like what you and Bradley were just talking about, going to Nemesis, going to the insurers, as you mentioned, you were reading specifically from the healthcare reimbursement manual, which is not a short manual by any stretch of the imagination. If anybody has any problems, they can't go to sleep, it's a great read. But, that's one of those things that, we have to see that we have to do our care, and then EMS needs to be recognized, as you mentioned, not as a transport agency, but as a healthcare entity that's doing quite advanced techniques out in the field. So we're getting close to the end, but I do want to touch on one other thing specifically. We think at times that they're not important, but ultimately when we get down to the end of it, every time we go to sign a letter, even now, it's like very truly yours, and I sign my name, right? You want to see that, hey, it may not be a handwritten note, but at least I was down there and I signed my name, and that's kind of giving that last little sign off. Same thing with our documentation, though. It's got to be signed off on, right?
Yeah, so it has to, usually be electronically signed by the author. But also we need to get a signature from the patient, right? We need to get a signature from the patient if you're an agency that gets some kind of reimbursement. And your agency may also require you to get a signature from whoever you handed off patient care to. That's huge. I wish more agencies did it. Who received this patient? You know, patient to ABC ER, room 7, report to RN, patient at hospital bed via scoot over, side rails up ×2, bed lowered, patient signed HIPAA form, care turned over to RN, patient wished well. RN who? Who was the RN? 10 minutes later, the patient's face down on the floor with a fractured face, and there isn't a single RN, because you didn't name one, that wants to take responsibility for receiving a report from that patient, right? And I get it. The name tags are, usually flipped over so you can't read the name. I don't think that's done intentionally. At least my my wife, who's an ER nurse, says that it's not intentional at all. Now they're usually covered in COVID suits, but if it's an ER you frequent, you should know the nurse's name. If it's an ER you don't frequent, shouldn't you be introducing yourself? So documenting the name of the person who you turn that patient care over to is important. Getting them to sign for that patient, maybe even a little bit more important.
Well, if there's plenty of different articles, and you can go to any of the EMS publications that are out there. You see this on a regular basis. Now, I mentioned to my students that every patient should have a minimum of 3 vital sign data points. You should have it when you see them, I call it the patient bedside, but whatever that patient bedside actually is, the car, the house, wherever, when you move them to the ambulance, and then when you hand them off to the hospital. Because I've seen plenty of reports that have come out. A patient died after ED realizes that patient was esophagically intubated, and this was identified before. And it said that it was a pre-hospital issue and it wasn't recognized. So I said, when you hand off that this is your patient, vital signs. If you've got anything in place, IVs, IOs, intubations, blind insertion devices, this is the status. And I've handed them off to Jason, and at least having that so that is documented, and that's key. Now, there are times in our profession in which our patients are thoroughly and completely unable to sign their document. They're either restrained due to being placed on spine board due to spinal injuries. They may even be in cardiac arrest. In that case, we understand that they can't sign, but there does need to be a rationale statement placed in there.
Sure.
In your documentation, patient was unable due to these circumstances to sign the document.
Yep. And that's absolutely correct. For that HIPAA form that most people refer to it as, it's actually technically called an AOB, an assignment of benefits form. The overarching rule, the simple rule, is that unless your patient's dead, the patient should be signing section 1 for themselves. Now, as with any rule, there's exceptions to that rule, right? If the patient's under 18, they can't sign for themselves. The patient's parents can sign for the patient in section 1. You've heard me use COVID exceptions. There's another COVID exception for section 1. If the patient is suspected to have COVID or presumed to have COVID or confirmed to have COVID, all favorite medical catchphrases for COVID these days, and you have their verbal permission, as long as it's documented in your chart, you as the EMS provider could actually sign section 1 for the patient. Now, if you listen to this again in 2022, and I hope this isn't happening still in 2022, and the COVID exemption is gone, only the patient or their guardian can sign section 1. Patients that are under 18 typically can't, with a couple exceptions there. An emancipated minor, that varies state by state. New York hasn't issued emancipation papers in over 20 years. A patient who is a parent, or a patient who is enlisted in the United States military who's under the age of 18 can sign for themselves as well, legally. If you have doubt about the competence of a patient in signing section 1, get a witness. There's a witness form up there, a witness section up there as well. Section 2, that next section, if the patient's unable to sign section 1, You need to have a reason, as David mentioned, of, excuse me, why the patient can't sign in Section 1. Now, that could be that they have some kind of mental or physical disability, even if they're over the age of 18, that precludes them from signing for themselves. You can have their legal guardian sign for them. You can have friends or family, under certain circumstances, sign for them in Section 1, in Section 2 as well. If they receive financial benefits on behalf of the patient, if they handle the patient's affairs, if they are a representative of an institution providing care or support to the patient that's not EMS and not the hospital, they could sign. So, for example, if you're picking somebody up at a skilled nursing facility, maybe from a memory care unit, and that patient isn't exactly of the mind frame to sign for themselves, the staff at the sending facility can actually sign for that patient. Same with our colleagues in law enforcement. A patient is in custody of law enforcement. The law enforcement officer, should they choose to, can actually sign Section 2 on behalf of that patient as well. That leads us to Section 3. Section 3 is the last resort. These are numbered in order of preference, not just numbers on a piece of paper. Section 3 could be completed if 3 pieces of criteria are met. And that's where the medic signs for the patient and a representative of the hospital. Doesn't have to be a nurse, doesn't have to be a doctor. It could be anybody that works at the hospital that's comfortable signing. This can be done when 3 conditions are met. The patient is unable to sign, and, not or, but and, there's no other person who could sign, anybody from Section 2. And the circumstances of why are fully documented. Like David mentioned earlier, patients with cardiac arrest, they're not going to be able to sign for themselves. I did a lot of critical care transport. Patients sedated and intubated is a really good reason why they can't sign for themselves. That's pretty valid. Patient refused is another one. It shows that you made an effort to get a signature. Patient in extremis, any kind of extremis, severe asthma attack, COPD exacerbation, trauma, stroke, anything that would prevent them from signing. It just has to be documented, right? The whole thing that we're talking about is documentation. If you have documented circumstances, it's absolutely fine. The other caveat with this, though, is if somebody signs, it's not the patient, they need to print their name that can actually be read. I guarantee you can't read their signatures for the most part, but you need to have them legibly print their name. So if anything ever comes into question, we know who the heck the signer was. That's important.
All right. So we have gone quite a while. We want to thank you, Jason, for coming on and talking. And as we've already talked a little bit about it in our chat around the episode, certainly going to have you back because there's we get into documentation. There's a tremendous amount of additional areas talking about patient refusals and those kind of things that we definitely need to get into. Sure. That we haven't even gotten there yet. So, but we are going to finish up for the evening. So if you would, just any last thoughts on where we are with documentation right now, and then if you would let our listeners know how they can get a hold of you if they have any additional questions. Yeah, for sure. This is, maybe like the 15,000 foot look. There's so many more smaller, intricate areas that we could get into. Refusals are one of them. Interfacility transport documentation is a whole nother avenue. And if you guys will have me back, certainly talk about some of that. And occasionally I do talk about clinical topics too. So, all right. But easiest way to get a hold of me is usually by email. That's J as in John, D as in David, H as in Henry, A as in Adam, A as in Adam, G as in George, jdhaag@gmail.com. That hits me at all my devices, both of my desks, my phone, everything. So that's a great way to get a hold of me. Yeah, that's all I've got. So it's been a pleasure tonight, gentlemen. I've really enjoyed it. Well, and like I said, we want to thank you for everything, because I think this is going to open up a lot of people's eyes as far as what documentation actually does, not only for them, but for the services, for the profession. So there's a lot. We'll certainly have you back on here. And so sure. Thank you for everything and for your time. Yeah, and a shameless plug, I just ordered a t-shirt and a hoodie. Oh, so I don't even have a hoodie yet.
Get some EMS Handoff swag, people. Order it. I could order it during a podcast. You can order it while you're listening.
Oh, that's awesome.
Right there. I don't even have the hoodie yet. I'm repping the red T-shirt.
It's 12. I'm in a hoodie right now, man.
Man, that's great. We'd love to hear that. Jeremy at Pursue is probably looking at that because he didn't think we would have orders this quick. That's killer. We absolutely love that, man. And so that does get ready to go into my normal outro right here.
Shipping and handling is only $7. It's okay. Do it. Order.
Do it. That's it. He's done the outro for us right there. Hey, guys, as we conclude today, we'd like to say that we always look forward to recording these episodes and engaging with each one of you. But however, without your feedback, we don't know what you're thinking. So make sure to drive by the GEMS podcast platforms and give us a shout out, subscribe, rate, and review so you get these episodes first. But now, as we mentioned at the beginning of these episodes, you have our website, emshandoff.com, that you can go and you can reach all of us. That is going live and out there. And Eric's been doing a great job. We have our socials out there as well. Make sure and hit Facebook, our Facebook group, 1,000 plus, actually 1,100 plus members. Shout out to each one of those because they engage every day at the EMS Handoff and on Instagram at the EMS Handoff as well. So make sure to go by and visit Pursue Outfitters, visit Culture. You'll see the EMS line there. Thanks to everything. And like I always say at the very end, take care, stay safe, do great work, and always remember the impact of your EMS handoff. Thank you, everybody.